and contemporary lands. We respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkwiden, Anishinaabeg, the Three Fires Confederacy, Ojibwe, Ottawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation.
Good evening, everybody, and welcome to the first open board meeting for Windsor Regional Hospital for 2022. As usual, I want to just start off by saying thanks to the staff at Windsor Regional Hospital, doing a fabulous job keeping our community safe, advocating for the public in our region. So good work to everybody at Windsor Regional Hospital, and keep up the great work. Next on my list is an announcement from the Windsor Regional Hospital Foundation. There is still time to get tickets to the Mega Money 50/50 draw. It is currently over $143,000. So please go to WRH raffle.5050central.com or just go to the wrh.on.ca homepage. It'll be there. And then really just some good news. Stage 2 planning for the new Windsor Acute Care Hospital is underway. So following the October visit and funding announcement from Premier Doug Ford and the Health Minister Christine Elliott, our team got right to work. A project management team is now in place. User groups made up of hospital staff, leadership, patient representatives will start meeting next week. And now we have a project vision and pardon me. And now we have a project vision and set of design principles to guide planning going forward. So I'm going to turn things over to Allison Johnson, Manager of Communications and Community Engagement, to talk about our role, the role we play, our community played in shaping the project vision for the future hospital. So take it away, Allison.
Hi, everyone. I'm Allison Johnson, Manager of Communications and Community Engagement for the new Windsor Essex Acute Care Hospital. As part of Windsor Regional Hospital's commitment to ensuring the community's voice is included in every stage of the planning process for the new hospital, we recently launched a survey. We wanted to find out what you think is most important when it comes to the design of the new hospital. Today, we're going to take a look at some of the results from that survey and find out how they'll be used to help guide the planning process as we get set to kick off Stage 2 planning. In November, we launched the Design Principles Survey. We asked hospital staff, community partners, and members of the public to share their priorities for the new hospital design. Participants had the option to fill out an online survey or share comments by mail or by phone. The survey was promoted in the media, on social media, on the hospital's website, and it was also sent to our community partners and our ambassadors by email. The survey ran for 4 weeks, and in that time, we received just shy of 1,000 submissions. When we started to go through those submissions, very quickly, some themes started to emerge. Those who responded to the survey told us they want a state-of-the-art building that is accessible, with large private rooms and more space for families so they can be part of the care. They want better access to services, plenty of parking, a supportive work environment for staff, and a hospital with the capacity to provide timely, patient-centered care, and a hospital that will serve the community well into the future. Note here that patients are right at the heart of these responses. In fact, the word patient was mentioned more than any other word in the survey, though it was followed closely by parking and access. Now, using the responses from the survey, we established a project vision and a set of design principles that will guide decision-making as we move forward through the process. The vision is to create a state-of-the-art treatment and healing environment for all those who we care for, a supportive workplace with the latest technologies to allow all of our staff to provide the most efficient and highest quality care in a new hospital that supports well-being and has the capacity to provide timely, patient, and family-centered care for generations to come. The guiding principles are based on some of the themes that started to emerge when we started to dig deeper into the responses. And again, no surprise, 63% of the submissions talked about using this opportunity to make the hospital experience better for patients and for families. Now, here is just a small sample of the related responses. Note you'll see words like dignity, privacy and confidentiality, wayfinding, parking, access for all, including those with physical disabilities, access to daylight, and spiritual care, including Indigenous healing facilities. And there you have it, private rooms and private washrooms. Those came up multiple times. Now, all of these factor into the first planning principle, and that is outstanding patient, family, and visitor experience. The planning team will focus on creating supportive and health-promoting spaces with opportunities for privacy and respite, as well as space and amenities that are accessible, welcoming, and support a diversity of culture, age, ability, and gender. Now, this means meeting or exceeding accessibility standards, creating access to outdoor areas, and incorporating daylight and outdoor views into the design. We heard that one a lot. Also planning multi-faith and spiritual spaces, including Indigenous healing areas, senior and family-friendly spaces, and gender-neutral washrooms. Another notable theme in the survey was safety and quality. People told us they want private rooms to prevent the spread of infection with appropriate ventilation, and larger rooms and large hallways so that patients can move safely around the hospital. And this leads us to the second principle, high quality and safe care. This includes support for integrated care delivery, enabling best practice and evidence-based care. And this will be achieved by incorporating private rooms and sufficient airborne isolation rooms, meeting or exceeding contemporary standards for hospitals and infection prevention and control, and separate areas for patients, staff, and materials to move around the hospital. In this way, we will no longer have to share an elevator with soiled linens, for example. Now, many responses mentioned a design that includes operational efficiencies, with efficient patient flow to minimize wait times, allow care teams to spend more time with patients, basically a design that limits the amount of walking for both patients and staff. So an operationally efficient design will maximize efficiency and promote timely access to appropriate care while optimizing the use of resources. And this will be achieved by standardizing rooms and spaces, designing flows that achieve timely and effective delivery of services, and co-locating interdependent services to reduce unnecessary travel throughout the hospital. The next principle will ensure that the hospital is the right size for today with the flexibility to adapt to meet future needs. And we heard this repeatedly. The rooms need to be bigger for patients. Patients have trouble maneuvering around the current and cluttered rooms, and they need more space. We also need room to grow. This would be to accommodate long-term population growth, an aging population, and also to handle any future pandemic and endemic surges. To accomplish this, the design team will consider strategies for accommodating future growth and balance the need for additional capacity and space efficiency. And this will mean incorporating approaches for growth such as adjacencies, soft space, and shell spaces that can be developed in the future. And it also means planning multi-use spaces while ensuring there's sufficient space for equipment and for supply storage. The topic of research and education was a popular one in the survey. People want space for learners and for engagement. They want proper training space for staff, students, and the opportunity for more collaboration within the research community. So using this principle, the design team will promote interprofessional rather than discipline-specific spaces and amenities, and provide opportunities for collaboration as well as for quiet study. The planning team will look for ways to create multi-use, shared and accessible meeting and learning spaces, and incorporate areas for care planning, research, education, community engagement, and brainstorming. Creating a healthy, safe, and inclusive workplace is the next principle, and both staff and the public feel that it's important to have a design that promotes safety and a place that staff can take a break, can decompress, store their belongings. Now, under this principle, planners will focus on incorporating space, technology, and equipment that protects and supports staff in care and service delivery. Also, creating spaces that are accessible and support wellness and diversity, and this includes optimizing adjacencies and designs to reduce walking distance for everybody. Safe facilities for changing, showering, securing belongings, respite and exercise, and again, creating access to daylight and outdoor areas, as well as meeting or exceeding existing guidelines and legislation. Words like innovation and state-of-the-art were popular in the survey. At a minimum, people want to be able to charge their devices and access Wi-Fi. Others would like to see technology used in the admitting process, for example, or to reduce wait times, a fully digital hospital, and smart technology. Using the principle, the teams here will focus on a design that enables state-of-the-art care delivery and transportation of specimens, supplies, medications, and patient meals using automated systems and robotics. And also using technology to improve communication and collaboration among providers, patients, and families. This means planning Wi-Fi and charging stations throughout, exploring systems like automated guided vehicles and clinical automation, providing online registration and scheduling, as well as space and technology for virtual visits and consults. The last principle focuses on sustainability. People told us they want to explore ways to minimize emissions, reduce the environmental impact in the planning, and explore energy-saving design features. So the team will focus on a design that incorporates environmental management systems to minimize consumption of energy, water, and materials, and minimize use of toxic materials, limit waste, and enable the practice of responsible disposal. To do this, the team will look for ways to meet or exceed leadership in environmental design, or LEED, silver certification requirements, consider condensing boilers and high-efficiency chillers, efficient pump designs, and heat recovery chillers, and water use reduction using efficient landscape. And again, the vision and these design principles that we shared with you will all help guide the decision-making as we move through stage 2 and beyond in the planning process. On behalf of the team, I want to thank everybody who took time to complete the survey, share your feedback, and provide input into all of this. It's an exciting time, and we look forward to working with you more in the future, introducing you to other members of our team in the coming weeks and months. We hope that you'll consider to join us and join us throughout this journey. Please visit our website, windsorhospitals.ca, and subscribe to our mailing list, where you'll find out future opportunities to get involved. I can tell you that we have coming up later this year some town halls that will focus on program and service specific areas, where you will have the opportunity to find out more about the planning that's going on in these areas and give further input into some of these specific areas. So we look forward to sharing all of that with you going forward. And thanks again for helping us with this part of the project.
I want to reiterate, thank you to the public that took part in providing the feedback. Over 1,000 individuals, almost 1,000 individuals. And that means there were a lot more people that actually reviewed the website and actually took a look what we were looking for. So thank you, everybody. Please sign up for the mailing list. It is important. Everybody knows that communication is important. We are doing our best to communicate out to the region, and we want you to ensure that you're up to date on everything that we're saying. So remember, please go to our website, sign up, and make sure you're well informed about what's happening in and around the new hospital. So thanks again, Allison. Great job. So next up, we have David Boucher with the President CEO report.
Thank you.
Anthony.
Oh, sorry. Did somebody have a question?
No, I was just going to say the minutes. Should we, the minutes from the last meeting?
Sorry. I don't know what the heck I was doing.
Okay.
It's like it's January 2022. I don't know what I'm doing. All of a sudden I forget. All right. Sorry about that. I should probably call the meeting to order too. So can I get any declarations of conflict of interest? Seeing none, thank you. Can I get a motion to approve the previous minutes? We've got Michael, seconded by Paul LaChance. Thank you, gentlemen. Questions or comments with regards to those minutes? Seeing none, all in favor? Perfect. Thank you so much. It's like the first time on the job. Now we will go to the report of the President and CEO, David Mouche. Sorry about that, everybody.
Thank you, Mr. Chair, and welcome everybody, and Happy New Year to everybody, all our board members, as well as our audience that's watching and those that will be watching the tape. So unfortunately, we're now, even I get the date wrong, it's January 6th of 2022. Not 2021, even though arguably you'll find out, you'll see we could do this presentation a year ago at certain points. What I'm going to outline is the following with respect to provincial projections, wastewater results, and I'll explain what that means, a current breakdown and a further breakdown of our inpatient COVID numbers with some age data, our current overall capacity at Windsor Regional Hospital, what is Directive 2, that was just issued this week, and our WRH staffing numbers who have been impacted by COVID up to date. So one of the things that was announced late last week was a concern with respect to the provincial projections when it comes to the overall impact of Omicron on the healthcare system, and especially the Ontario healthcare system. Clearly, one of the issues is it is rapidly spreading through all of Ontario because we're not doing all the testing, arguably, that should be done of those individuals who have symptoms. We really don't know how many people are positive in the province of Ontario as it stands now. What we do know is that at a minimum, it's about 10 to 12,000 a day. It's 3-4 times that amount in a given day, if not greater. What we do know about Omicron is generally, if you have two, and especially if you're boosted, you generally have mild symptoms if you're infected with it. Unfortunately, those without vaccines are still negatively impacted by Omicron to the same extent that they were with respect to Delta and the previous variants as well. One of the concerns, though, is that even though the individuals with 2 or 3 doses generally will not require hospitalization or ICU care, just because it's going to be impacting so many people, hundreds of thousands, millions of people in Ontario, even a small percentage of those individuals needing hospital care results in a large number. So what this projection shows, we were shown this late last week, I think it was New Year's Eve, with respect to what unfortunately we need to expect in the Ontario healthcare system based upon just recent information, recent projections. And you'll see on this chart, there's a baseline of about 17,000 hospital bed capacity is the gray line. The stuff in the blue is what is going to exceed our current hospital capacity when it comes to bedded capacity. And that's going to be made up of the orange or brown lines underneath where it's projected COVID inpatients and then just projected non-COVID inpatients. And when you add those two together, it's going to exceed the amount of beds we currently have in the healthcare system. So that required Ontario to act, and they did act with respect to not only, I'll talk about a little bit later, Directive 2, but also they acted with respect to the public health measures and implementing what is known as a modified stage 2, or what was a stage 2 previously implemented with respect to the closure of certain businesses for at least 21 days and possibly even longer, depending on how this rolls out over the next period of time. One of the indicators we've looked at, which is fascinating in and of itself, is with respect to wastewater results. And Mike McKay from the Great Lakes Institute for Environmental Research at the University of Windsor We've been in regular communication. His data is used by WeChew on a weekly basis with respect to predicting what's going to be happening in our community when it comes to COVID, as well as if you go on the Ontario Science Advisory, COVID Science Advisory table, one of the recent reports that was done, I think around 2 months ago, focused on wastewater, and Mike and his team were part of that report and part of feeding the information into that report. And I've personally been interested in this, is if you look across internationally, definitely in North America, the use of wastewater has been a good predictor on what to anticipate. It's usually one of the first indicators of what is to come when it comes to COVID in our region and other regions across the world. So what this chart shows is what's been going on since July, and you'll see the pink dots are the SARS COVID numbers with respect to the amount of COVID that is being detected in our community and in the wastewater. And then you see a dramatic rise in and around right at the end of December into January. And at the same time, the blue dots is the percentage of that rise that is made by Delta, the Delta variant. And you'll see that's dropping. And it drops rather dramatically. It keeps dropping. What's interesting is what's happening right now is the data with respect to the sample has been sent off to get the genome sequencing to determine if it is Omicron. It's going to be. So the differential in talking to Mike is between this blue dot and the pink, or what we're seeing in cases is the gray in the background. That's the actual cases in Windsor, Essex, which we know is even higher than this amount reported on a daily basis. The difference is attributable to Omicron, that's what's creating these cases. If Delta's this low and Delta's only being picked up by this amount, Omicron is now taken over with respect to COVID at this point. What's interesting is some in the community will say, Omicron's been around for, over a month. In November, it was first detected in Ontario. So therefore, if our hospital numbers didn't go up in December, we should be fine. Well, the issue is it might have first been detected in Ontario in November. It really wasn't around in Windsor, Essex until about Christmas time and a little bit later, as you can tell from these numbers. Basically not until almost New Year's Eve in January. So it's that last week of December where we started to see a rise in the numbers, in the SARS, in the COVID numbers. And at the same time, clearly from this, and once they get the results from the genome testing, it'll confirm it, is the differential is all caused by the increase in Omicron. What they do have is back on December 15th, the percentage of Omicron, because they did have the genome results came back, was only 2%, December 15th. So that shows you what's happened between the 15th and the end of the month, the end of the year, let alone the first 6 days of the new year. So what is happening is those results should be coming out. And usually this is an indicator that we start seeing this in the community 1, 2 and a little bit weeks after you start seeing this increase is when we start seeing it in the community. And you kind of see that as the numbers started going up here, again, the gray followed after we started seeing a rise in the middle of December with respect to the COVID being picked up. So like I stated, maybe with Omicron, it'll be a little bit quicker because it moves a little bit quicker than Delta does. So 1 or 2 weeks. So really, unfortunately, what I'm trying to get at is we haven't seen the full impact of Omicron in our community, and definitely not in the hospitals for another couple of weeks. Then we're going to feel the full brunt of Omicron in Windsor, Essex. We had talked about this. We had meetings as a group at the end of the year and into the new year, and said the weeks we have to be concerned about are definitely January 10th and January 17th for sure. is going to be some unfortunate, difficult times for the overall healthcare system. What this chart shows is the history of the pandemic in Windsor, Essex, when it comes to our inpatient activity. And it goes basically to the start of the pandemic. And if you look at the far left over here, this is the first wave of the pandemic and the numbers of COVID inpatients we had at Windsor Regional Hospital. So wave one was not as bad as what we were kind of anticipating it to be. Where we really had the difficult time was in wave two, which is the second group here, where on any given day, the highest amount of inpatient was close to 70 on any given day of COVID positive inpatients. And then this wave here is 3, which happened in the spring of this year, of 2021, sorry. And if you remember, that's not, about half of that is caused by Windsor Essex cases. The other half, or the numbers of inpatients, were created by us helping out the rest of the province. And we brought over 100 patients from the GTA to Windsor Essex and cared for them because of the GTA was struggling in wave 3. But now over to the right, you can see what's happening with respect to wave 4. And then unfortunately, the number of our inpatient is on a straight line up right around the 6th. We're starting to see it as predicted by the wastewater analysis on the previous screen. So where do we sit right now at Windsor Regional Hospital? At 2 o'clock today, these are the number of cases we're seeing in the hospital. It's gone up over the last few days, as stated, where we have 44 inpatients. Then there's a calculus still being discussed across the province with, especially as time evolves. It's going to be more so, is individuals, unfortunately, are going to come to the hospital. They are going to be infected with COVID. That's not why they're going to be here. They could be here for something else. And that's probably going to, unfortunately, increase as time goes on, as we move towards most likely an endemic phase of this pandemic, but still to be seen. Again, the number that jumps out that's been consistent from the start is the issue of the ICU, and those needing critical care are unfortunately unvaccinated. And the 298 keeps creeping up, and in large part, it's unvaccinated or the individuals who are passing away. So I wanted to have Dr. Saad talk about this, because one of the issues people are saying is, oh my God, look, out of 37, 19 are fully vaccinated. Isn't that a problem? Doesn't that mean that the fully vaccinated are just being impacted? We have to remember right now we're closing in on 90% of the population that's fully vaccinated, has 2 doses. So those 19 are being pulled from about 90% of our population. The 16 is being pulled, or 17 of them are being pulled from 10% of our population. So when they say your chances of getting COVID, let alone being hospitalized, are greatly increased if you're unvaccinated, it's because of that statistic. So I'll just pass it over to Dr. Saad to explain to the community and to the board the impact of the vaccinated and what type of patient population who's even vaccinated is having to be hospitalized.
Thank you, David. And I'll just jump off from the last comment that you made, which is very important, is those 2 numbers, although being very close together, the 19 and the 16, are not even close to being similar to each other. Because if you figure for our region of 400,000, I think the last estimate from WeChu was we had anywhere from 40 to 50 that were still unvaccinated, 50,000. So in that 40,000 population, you have about 17 people that are admitted to hospital that are being drawn from 40,000 people, whereas 19, or a similar number, is being drawn from 350 or 360,000. So clearly the percentages and the chance of you ending up in hospital varies significantly, whether you're fully vaccinated, partially vaccinated, or if you're completely unvaccinated. The other thing that's important to note about those numbers is the further breakdown and the demographic of the patients that make up those numbers. In the first two waves that he showed in those graphs, we were admitting 20-year-old, 30-year-old, 40-year-old people who had almost no comorbidities. An unfortunate 20-year-old died with absolutely no risk factors. We had migrant workers who died who had no risk factors and were otherwise healthy. Those that died in their 30s and 40s were maybe had one risk factor like high blood pressure. What we're seeing right now with those that are fully vaccinated, the ones that are getting admitted to hospital, and we don't have any in the ICU now, but when we did, had significant comorbidities. And we're talking transplant patients, patients with multiple issues, including blood pressure, cholesterol, diabetes, heart disease, and at the extremes of age, as is shown by this graph here, where you can see the number who are fully vaccinated the majority are 60s, 70s, 80s, and we have a couple in their 90s as well. And even partial vaccination it's a small number in sample size, so I wouldn't focus too much on that. But if you're unvaccinated, you can see the trend is anywhere from 0 to 9-year-old category all the way up to the 80-year-old category, and they're evenly distributed, similar again to what we were seeing in previous waves. The other thing that's important to note about the Windsor regional numbers is it's very consistent with what happening in the rest of the province, as well as in other countries that are dealing specifically with Omicron, is you're getting a lot more hospital admissions with patients being admitted to medical wards and not necessarily people being admitted to the ICU. Again, if you're fully vaccinated. The fully vaccinated and boosted, when it comes to Omicron, have almost a less than 1% chance, close to zero, of ending up in the ICU or dying from COVID. That is very significant and that people need to recognize. Whereas if you're unvaccinated, although Omicron looks like it is causing milder disease, as was stated previously, even milder disease, the fact that it could get to everybody and is going to permeate through the population, you're still going to have an absolute number that could overwhelm our healthcare resources, which is why we are being told by the ministry to monitor for those medicine beds, because that's where our crunch is going to come. In the first two waves, we were focusing on critical care capacity. This wave, specifically with Omicron, we're focusing on medicine bed capacity, because that's what it looks like in terms of the majority of patients that are being admitted to hospital. So for those that, again, I get a lot of questions and detractors who say vaccines are not working. We have to remember, these are not what we call sterilizing vaccines, meaning a sterilizing vaccine will prevent you from getting an infection in the first place. And there are very few vaccines in medicine that do that. What these vaccines do, which is what all the other vaccines are meant to do, is to prevent significant serious illness, prevent hospitalizations, prevent ICU admissions, and most importantly, prevent deaths. And there's no question that these vaccines are doing that, and they're keeping patients, vaccinated patients, out of our ICUs and preventing them from dying.
Thank you, Dr. Saad. So just to give an idea, I'll move into what our overall capacity is right now at Windsor Regional. Actually, it looks a lot better today, and part of it has to do with the implementation of Directive 2 already and starting to have the impact of that on our overall. The goal here in hospital healthcare is not to get to 100% occupancy. You don't want to run at 100% occupancy. You want to be, in literature, it's about 85%. We're not even at that number now, at 85%. We're close, but we're not there yet. And if we're there, we're counting family birthing beds and some other beds that are not medical surgical beds to get to that number. So if you look at this at 3 o'clock today, and of course it's changed at 5:30, is currently we have 7 out of 51 of our critical beds are open. 11 out of the 126 surgical beds are open. 17 out of 338 medicine beds are open, and 4 out of 16 pediatric beds are open. This is over both of our campuses, split over the 2 campuses, except for the peds beds is located at the Met campus. And in addition, we have family birthing and mental health beds, which are dedicated to those populations. So we have a little bit of room, but this room can evaporate. And unfortunately, with the projections, it's going to evaporate very quickly. What we know about Omicron and what they're ready for and what we've seen in other jurisdictions is it hits quickly. It happens very quickly. We haven't felt it yet. We're just right at the start of Omicron, as indicated from those previous charts. We're not where it's going to be when it comes to pressures on the Ontario healthcare system and or the healthcare system in Windsor, Essex. That's still to come over the next 2 weeks. The saving grace is because it moves quickly, it possibly can be over quickly, meaning by early February, by the middle of February, hopefully we start going back down and we can start to stabilize. The issue is over the next 4 to 6 weeks, we're in for a tough ride based upon what Dr. Saad stated and based upon what we've already started seeing with respect to the patients who are impacted by Omicron. And again, we are at the early stages of this in Windsor, Essex. So we talk about what's Directive 2. Directive 2 was issued back during the first wave. And what this does is it creates physical bed capacity in the province of Ontario and also frees up health human resources that generally takes care of the patients in those beds. So what there's been a pause on starting Wednesday of this week at 12:01 a.m. is what is called non-emergent and non-urgent surgeries and procedures need to be stopped. This applies to every single hospital in the province of Ontario. It also applies to diagnostic imaging and ambulatory clinical activity needs to be stopped. Now, people might ask, diagnostic imaging and ambulatory clinical activity, that's not beds. People get that and they go home. Why is that needed to be stopped? Again, they're looking at health human resources, is to ensure that we focus on the patients, the inpatients who need these activities, as well as ensuring we have the health human resources available to handle possibly what's coming with respect to the patients. And it's going to be all hands on deck. So someone working in diagnostic imaging might end up being on the floor helping out the clinical staff. We hope we don't have to get there, but we have to be ready for it. And that's what's, again, being projected. So some people also ask, what are we looking at? What kind of numbers are we looking at on a daily basis? So we do approximately at Windsor Regional Hospital between the two campuses, approximately 80 non-urgent emergent surgical procedures a day. And on a daily basis, we complete 20 to 25 non-urgent emergent CTs and 10 to 15 non-urgent emergent MRIs a day. So unfortunately, that's what's going to be paused for a period of time. Again, people will say, well, that's going to create another backlog. We're going to be backlogged. How are we going to catch up? One of the positive things that we've done as an organization, and so proud of the team, to give some context, back in November of 2019, the wait list was over 6,000, to be exact, 6,370 non-urgent emergent surgical procedures. Right now, not including what didn't take place yesterday and today, is we're at 3,452. So we've actually, since 19 to post-COVID, we actually almost cut the wait list in half of those people waiting for urgent or non-urgent or emergent, non-urgent or non-emergent surgical procedures. We've cut it in half, the wait time, the amount of people waiting. How did we do that? Is I list the items we did where we reviewed procedures and surgeries, where we moved certain things to one site to gain better efficiencies, to get more procedures done. Reviewing procedures to move out of the ambulatory setting and into the community, again, in order to be safe with respect to COVID and get those procedures done, one of which is the eye program. We've been able to sustain that by moving it in to a facility operated by Dr. Tafor, along with the other ophthalmologists, and it's a hospital site. It's been designated as such, but we're able to continue to do eyes there. Again, consolidation to one site, and then looking at best practices, things like same-day home joint programs. I know it doesn't sound, wide-awake foot and ankle surgeries to ambulatory, and then moving certain procedures to cysto and urology. So one of the positives coming out of COVID, if there's a list of them, is how it's resulted in all of the clinical professionals, examining best practices, moving towards best practices in order to try safely to get more procedures done in a more timely fashion. So yes, if you were booked for a surgery, unfortunately, in the next couple of weeks, that's non-urgent and non-emergent, you're most likely going to get contacted and it will be delayed or postponed. But as we did following the implementation of Directive 2 the previous time, at the start of COVID, we were able to make some great strides in reducing that wait list to levels that are half of what existed prior to the start of COVID. So, and that's a full team effort. Now, focusing on how this has impacted our staffing with respect to COVID and where our numbers stand. We have approximately 4,800 total staff at Windsor Regional Hospital. That's made up of employees and professional staff. Right now, we have approximately 190 staff who are negative for COVID, but because they had a close contact of a positive or symptomatic in the community, a good proportion of them are self-isolating at home, which is about 3.9%. 173 of our staff currently are off due to COVID themselves. Again, the bright side of things is most of them all of them are doubled and or boosted vaccinated. And already we've seen 61 total staff have already returned to work after they've had to isolate pursuant to the public health rules, even if they were COVID positive and or close contacts or symptomatic but negative. They followed the rules and they're cleared to come back and safely be in the hospital and have been cleared of their of COVID-19. So this number is going to continue to ebb and flow on a given day. We saw a lot of activity, of course, over the holidays with our staff. They're human beings as well. They had, small family gatherings in light of public health measures. But again, because Omicron was so prevalent, it has impacted our staff as well. So, Mr. Chair, that is my report. And I tried again to dig deep into the numbers as best as I could. And I have to give a lot of credit to our team here at Windsor Regional Hospital for putting these numbers together. I can tell you over the last 2 years, there isn't a day that goes by that we aren't crunching all sorts of numbers with respect to internal data. People will say, well, why don't you put up the chart with respect to the age groups every day? Listen, I wish we could. It takes a considerable amount of time of staff to start pulling that together when we really have to focus on looking at bed numbers and submitting that to the ministry and doing calculations not only for a region, but for the whole province and feeding into that. So as we move forward, I just asked for our decision support team to give me these numbers today, and I promised I would not ask for them again, and they wouldn't have to repeat the ages, but I wanted to be 100% accurate tonight. And so I give them a lot of credit with respect to this. And the last group I want to thank, and there's everyone I could thank, but really, we have in the back rooms is our lab staff. They have worked their tail off for over 2 years. And they've been busy before, because you got to remember, they're not only doing COVID stuff, they're doing all the other lab work for our patients in our hospital. Over 650 patients, plus patients coming in for ambulatory procedures and processing tissues, processing blood, all the blood work that's being done. And they've done it tirelessly. And I can tell you, there's one individual, Lucy DiPietro, who sends texts to myself, Karen, Erica, and Wasim for the last 2 years on a daily basis with respect to every single positive that we come across in the hospital and or our staff, and along with our employee health, and keeps us advised. And she's been doing that pretty much. I don't think she sleeps, because we start at pretty much all of us, except for Wasim, at 4 o'clock in the morning, and Wasim gets her texts all the way into the late evening, and Karen and I are asleep. So, but Lucy, along with the rest of the lab team, are just amazing. The work they do, and they really are unsung heroes of COVID, because a lot of this data and a lot of this information is coming from them, and they have to do a ton of work, exhaustive work. So I have to thank them. So, Mr. Chair, that's my report.
All right, thanks, David. Questions or comments for David? Wow, that was comprehensive. So I just did my quick math, by the way, because everybody's thinking it. It was 7.3 times more likely to be in the hospital currently. Obviously, this changes day to day, to just be admitted, but it's infinitely more likely to be in the ICU. So if for all the math people out there, that's a big number. So please, please, please just go get vaccinated is the only thing I can say. Congratulations to you and your team, David. And thank you everybody for putting in the extremely long hours during these tumultuous times. So again, thank you. And if there's no more comments, we have a new standing report from our Chief Nursing Executive, Karen Rydell. Karen.
Thank you, Mr. Chair. And good evening, everyone. And as David mentioned, I would like to start by wishing everyone a very happy New Year 2022. And as this is my first CNE report to the board, I did want to provide a bit of background information and focus on one particular topic that really leads off of what David had talked about. And although it's received a lot of attention during the COVID pandemic, it's been a concern for much longer. And Matt's going to run the slides for me tonight. So Matt, if you could go to the next slide. So this actually marks my 32nd year as a registered nurse. And when I graduated in 1989, there was already a nursing shortage globally. And unfortunately, we're expecting to continue that. We haven't made much progress globally. We're looking at about a 9 million nurse shortage by the year 2030. And that sounds like it's a long time away, but this is 2022, so it's only 8 more years. And the World Health Organization actually identified 4 major themes that they really wanted to get a call out to all providers across the world to really address this crisis. And although it's well beyond the scope of this particular discussion, there's much excellent information available at the link. And I won't read these themes to you. You can see them on the screen, but we will thread those through later in the presentation. So Matt, if you can go to the next slide, please. Thank you. So drilling down, when we're looking at Canadian trends, so that was global, the Canadian Nurses Association has actually published similar data reporting lagging growth rates of nurses as compared to population growth. And there was a recent study out of McGill that actually is predicting an overall nursing deficit of 60,000 full-time equivalents in 2022 in Canada. So this is very significant, obviously concerning nursing being almost 50% of our workforce in healthcare, so very critical. Matt, if you can go to the next slide, please. And then at the Ontario level, when we look at this data, this is actually from the College of Nurses webpage, and you can see the overall growth of nurses year over year. And you can see there's not really a significant difference, especially when you're looking at the population growth rate in Ontario. And keep in mind, we are having net losses of nurses each year. So in order to keep up and stay ahead of the population growth, we need net growth. And the numbers that we're adding each year from a registration perspective are just not keeping up with that. We also know that in Ontario, we actually are a large supplier of nurses to all provinces in Canada. We actually supply more nurses based on how many are graduating. We're supplying more than would be our usual share, let's say, based on how many nurses are graduating. And then locally, we know that we are challenged by also supplying nurses to our neighbors across the river in Michigan. So all the nurses graduating certainly do not register in Ontario and are not available to work in Ontario. So all that becomes important as we're looking for strategies in Windsor, Essex on how we can sustain our workforce. Matt, if you can go to the next slide for me, please. So our current state at Windsor Regional, as David said, we have over 4,000 professional staff and employees. And when we're looking, 1,438 of those are registered nurses, 37 are nurse practitioners. We have close to 400 RPNs. And then we have a large team of brand new addition to our nursing team, which are our nursing externs. And I'll talk a bit about those, but we added over 188. That gives us a total of 2,049 nursing resources at Windsor Regional. Our current total vacancies are 193, and that is at this point in time. When we look back last year and the year prior to that, pre-COVID, which we have to remember was also pre having assessment centers, before we had vaccination centers, really before COVID hit, our vacancy rate was 140 in these nursing categories. And so sitting at 193, there's not really a statistical difference with our vacancy percentages. So that's a good thing. So it hasn't gotten worse during COVID. And when we look at the top 3 reasons for nurses leaving the profession, they still are the same as they were 3 years ago. So we haven't seen an appreciable difference in the reasons nurses are leaving, and really no statistical difference in the overall percentages year over year. And I know that has been a matter for debate, both in the media and through various other sources, and looking at what are the impacts of the COVID pandemic on the nursing profession. And although there are some factors that I'll talk about in a moment that are important, really we haven't seen mass exodus at this point from the profession. So that's very important to keep in mind. So what our challenge really is moving forward is to maintain and then also grow this workforce. So Matt, if you can go to my next slide, please. So when we're looking at research, and I know that there's some on this board that are going to be very familiar with this information, that the things that are important to nurses and healthcare workers in general are typically not necessarily monetary in nature. Really, our professions are really looking at career and professional development opportunities, so both clinical and leadership development, staffing ratios that allow us to provide quality patient care, built-in flexibility to address acuity and patient needs. So not just a one-size-fits-all staffing model, but something that can adjust based on the needs of the patient. Opportunities for staff to be engaged in quality improvement, research, and governance. An interprofessional practice model and environment that really ensures collaboration and allows for that delivery of excellent patient care. An accessible, supportive, and approachable management that has excellent communication skills. Innovative recruitment and retention programs to attract and retain staff, and a safe workplace that is free from violence, harassment, and injury. These are the factors that we can control very easily. They do not rely on a lot of external agencies and legislation. These are things that are well within our control at Windsor Regional that we can focus on. And that will allow us to have both a short, mid, and longer term strategy for that sustainable workforce. And although I'm talking a lot about nursing literature, this does apply to other categories of regulated health professionals and other staff that support health and human resources. And if we can go on to the next slide, please. So another thing that we did is we really do like to validate that the findings in the literature are actually what our staff are actually wanting. And we have conducted staff surveys. And what we're finding is what this research is saying is actually what our staff are wanting too. So our staff are very proud of the work that they do, and there's many things in the hospital at Windsor Regional that they do not want to change and want to keep doing. They're very proud of the interprofessional teamwork models that have been established. They're proud of the work that their colleagues do, the excellent patient care being provided. They love the new support staff that have been put into place. They want to keep the unis and other new staff that we've put in place during COVID to support them. And I can't leave out the one point. They are very, very proud of the work that they've done during the COVID pandemic. It's the hardest work that many of them reported that they've ever done in their careers, but they're very proud that they've been able to support our community and others, both across the province and from other provinces. What our staff do want more of is full-time positions. They want more staffing support, such as float teams. Gives us the flexibility when we have staffing issues like we're experiencing right now with COVID. They want more time with the patients. They don't want to be rushed. They want to provide that quality care. They want to be appreciated. They want opportunities to be involved with changes and improvement. They want more access to education, ongoing clinical updates, and professional development. They want work-life balance and flexible scheduling, regular performance reviews, and staff meeting and engagement opportunities. So really, again, exactly what we saw in the literature is what our staff are asking us for. Matt, if you could just go to, I believe this is my last slide. So I just wanted to finish off with summarizing, might be a little hard to read on the screen there with the background. But what we want to focus on for this coming year is really advocating for things that have been successful this year. So our extern program was provincially funded as part of the COVID strategy. And also we were provided with a recruitment and incentive program. And we certainly would like to advocate for that to continue in the future. It did provide a lot of opportunities for us to really reach out to different staff and recruit them to the organization, and that's been very successful. Converting temporary positions into permanent positions are much more attractive and provide stability for our staff. Evaluating those opportunities to expand the float teams for critical care in the emergency department. Really expanding staff appreciation and recognition programs. We have a great above and beyond program. We have our honor roll, but there's other opportunities that we could look at and do more real-time feedback and recognition for our staff so that they do feel appreciated. That is really something that they really want to hear from us, that we appreciate the work that they do. And last but not least is really continuing our implementation of our interprofessional practice model. A lot of this aligns with my colleague, Dr. Wasim Saad's model that he is rolling out, including the quality improvement office. So really focusing on education, competency-based orientation, annual professional development opportunities, regular career-based performance evaluation and development, interprofessional program-based practice committees to provide staff an opportunity to engage in improving their actual work environment and the care being provided, active program-based quality improvement and research opportunities for frontline staff, continuing to promote manager accessibility and interaction with staff, and expanding our staff recognition and appreciation programs. So in future months, we will be bringing updates to the board to keep you informed of our progress with this work. We're very proud of the work that we've done over the last few years throughout COVID to maintain quality and safe patient care, and want to be able to continue to do that in the future and with our new hospital coming in the next few years as well. So thank you, Mr. Chair. That's my report.
And a fabulous first report it was. So thank you for that. Does anybody have any questions or comments for Karen? No, well, thank you, Karen. I appreciate the time, and that is very, very good information. And for everybody at home, a UNE is an undergraduate nursing employee, and those are college and university students that have not been fully licensed yet. So great. I closed my agenda, so bear with me for a second. So next on the list is our Schulich Report with Dr. Jacobs.
Thank you, Mr. Chair. I have a very brief report today. Like most schools, Western University has transitioned to going back to being online, so that did affect our medical students as well. Our first and second year students are virtually in class once again, although we are still able to continue with our clinical skills training in person. I feel like I'm giving the same report of last January, which is the stuff that matters we're doing in person, and the stuff that matters less we're doing online. Our hope is, as David mentioned earlier, that this burns quickly and that we can then get back to some degree of in-class experience for our students, because I think it does benefit them. But at this point, we are continuing with mostly online learning and online final examinations. When we look at our students and their performance this year clinically, the ones who were predominantly online last year, we did see that there were a number of areas where we feel that we could have done better with respect to their education. There are some consistent gaps which have come across our trainees. We're working with them and probably creating some extra opportunities for them to get to make up those areas. And so we're still optimistic, and I expect certainly that by the time they get to the point of graduation, we'll be able to catch them up enough. But it's a lot more of a dance than in previous years, and trying to make sure that they meet all of their competencies. So it's been a challenge that way, but we're up for it certainly, and our students are as well. Other issue that I want to let everyone know about is we are once again calling for applications towards our awards of excellence here at the Windsor campus. Many of our staff, faculty, and students have gone above and beyond over these last 12 months, and so we want to recognize them as well. We will be putting out a formal call for applications, but if there's anyone that you can all think of who is especially deserving, I'd love to hear them, hear those reports. In a perfect world, we'd love to be able to host this event as an in-person celebration as we had in previous years. I'm not banking on anything for May as of right now, but for now, we're going to at least plan to celebrate people. How we do it, we'll get there as well. I already see David was ready to jump at me when I said we're going to have a big party. No plans for party, but definitely plans for celebration of people. So we'll plan for that as well. And the last item on my report is really more of a question. I noticed a photo over David's left shoulder, and I got to be honest, it does seem to be Dr. Wasim Saad in a framed picture there. I'm curious about that, and I want to know what I can do to get my picture next to David as well. But that's all I have for my report. Thanks so much, Mr. Chair.
Perfect. Thank you so much. So David, is that Dr. Saad? And is it because he always needs to be looking out for you?
He came into my office today. He must have put it there. And I think he went into Karen's office too. Karen, point to that one on the back wall there, Karen. Oh, he's on. Yeah. See, you know what? He came into our offices and he put his photo there. Yeah. That was his Christmas gift to the two of us.
Well, it was very nice. I really thought it was so he could keep his eyes on you, but that makes sense.
Oh yeah, they are moving. Yeah, you're right. Yeah.
All right. Thank you for that report. Does anybody have any questions for Dr. Jacobs? No. Okay, wonderful. So next up, we have the report from the treasurer, Penny Allen. Penny?
Yes. I think Mark's going to put some slides up for me. Yes. Okay. So it's as at the end of November 30th, 2021. And the financial results of the hospital operation is 4.4 million deficit for hospital operations year to date. The net deficit after the building amortization is 5,504,000. COVID-19 unfunded but eligible expenses total 3,632,000 to date, and ineligible total based on the current reimbursement rules, it's 2,466,000. COVID has resulted in non-ministry revenues and unearned volume funding being under budget by 8.5 million. No indication as yet to whether the ministry will fund the non-ministry revenue shortfalls. So that's the hospital operations. The COVID-19 impact on expenses, 2.5 million year to date in extraordinary expenses and 3.5 million in lost revenues for a total of $6 million as is currently ineligible for funding. So that's not great, but wait and see. Revenue. Base and one-time funding is 23.8 million favorable due to amounts that have been accrued for non COVID-19 reimbursements. These include the first quarter and second quarter incremental expenses and temporary physician payments, vaccination and assessment center funding, and nursing extern funding. So there's a lot of COVID revenue things too, that are favorable. Patient services revenue, 1,619,000 favorable, relates to uninsured patient revenue from the ministry and higher diagnostic revenues, which are offset by higher medical staff remuneration expense. So that's the revenue. Then the last is the expenses, 28 million. Yeah, there we go. 28 million year-to-date unfavorable variance in expenses. The majority of these expenses are COVID-19 related and are confirmed or eligible for funding, which is good. Drugs, 1.6 million unfavorable. Systemic and renal drugs are funded by Ontario Health, and additional drug expenses in retail pharmacies are offset by the recoveries. Other supplies variance of 8.9 million and includes 3,561,000 in additional Evolve HIS project costs due to COVID-19 delays, which have been funded by the ministry. So that's good too. 3,135,000 for referred out vaccination center expenses. City of Windsor and County of Essex EMS are also fully funded, those expenses. And the 1,730,000 referred out cataract procedures, which are fully funded. So that's the presentation. I could make a motion. Okay. Unless there's anybody.
Can I get somebody to second that, please?
I just to approve my report, which is from December 2021, but the financial information is effective November 30th, 2021.
Perfect. And that's going to be seconded by Genevieve Eshok. Thank you, Genevieve. Questions or comments with regards to any of the information that Penny presented or what was in your package? Seeing none, all in favor? Perfect. Thank you.
Okay. Mm-hmm. And I guess it's me again, eh?
It is.
The consent agenda. I just have a motion, and that is that the report from the December 2021 Finance Audit and Resources Committee meeting be accepted, the report.
All right, seconded by Dr. Freeman. Thank you, Dr. Freeman. Questions or comments with regards to that? Seeing none, all in favor? Wonderful. Thank you so much, everybody. So within your package, we have the media report there for your information. We also have the date of our next regularly scheduled board meeting is Thursday, February 3rd at 5 o'clock. Have one birthday, Dr. Sababal. I hope I didn't butcher your name. I will get it right. Perfect. I will get it perfectly one time, but happy birthday this month.
Thank you very much. You got it perfectly. That was my birthday present from you. Saying my name correct. I love it.
All right, good. Anyways, everybody, again, please stay safe, mask up, get your booster shots, or get vaccinated for the first time. If you aren't vaccinated, you are able to walk into our vaccination center and just say, I have not been vaccinated, and they will take you right away. I bet you they will move you to the front of the line. So please just if you're driving by, pull into the parking lot, get your first vaccination, and let's put this pandemic to bed. With that, can I get a motion to adjourn? Paul Lachance, seconded by Dan Wilson. All in favor? Wonderful. So just for the board and Matt, can we load up the in-camera portion straight away? We do have a couple people waiting for us in the waiting room. So again, everybody, we'll see you in 2 minutes. And I believe there will be a media scrum as well. So I believe David Wasim and Karen will be out for a few minutes. So again, we'll see everybody in a few minutes. Thanks, everybody, and have a good night.